your fearless facilitator.
Hi, Patrick.
Everyone can, okay, so I'm coming through loud and clear.
Yep, good morning.
Good morning. So this is a bit of a departure. Not only the fact that we're having a virtual meeting and not an in-person meeting, but the agenda before you is a bit of a departure from what Wes, Diane, and I, and Carol have been thinking about for this particular month. But given the urgency of the COVID-19 sort of affliction, pandemic, whatever we want to call it, and our response statewide and locally, we thought it would be good for everyone to have a check-in. And so that's what we're going to do today. And you can see by the agenda that most of the time is going to be spent by different folks from our most of our 9 counties, giving us a report from the field, or maybe a report from the trenches about their own dealings with COVID-19. Before we do, though, a little bit of housekeeping. If you would mute, and that mute button is in the upper right-hand corner. Be sure and mute your phone or computer or tablet when you're not speaking. That would be great. We will dispense with introductions, and I think we can have a good idea of who's here just through the chat box. And so if you'd like to see, currently we've got close to 50 people on the line, which is wonderful. Thank you all for taking the time out of your busy days to do this. And let's get started. I am scheduled to give a little bit of an overview of some epidemiological stats, but before we do, Wes has prepared a short PowerPoint presentation, Wes Lucky, that I think will be very helpful in understanding just where we're at from a socioeconomic determinant point of view in our ACH, in particular, and how we might be able to handle effectively the COVID-19 challenge. So are there any quick questions or quick comments from those of you online before we get started? I know that Dr. Person, we definitely need to get her in a slot between 10 and 11. Dr. Pearson, if you're on the call already, just know that we will make that happen. Okay, so without further ado, Mr. Lucky, would you like to walk through your brief summary?
Sure. Can you all hear me?
Loud and clear, Wes.
Yeah.
Oh, great. Thank you very much. It's great to be here with you all today virtually. So Chelsea has a very short presentation. I'm toggling through several screens here, so give me just a second to see where we're at. Okay, so if you could go to the second page, Chelsea, please. So this is a summary of some information that Patrick and myself presented at the last Leadership Council, which being somewhat of a data geek or data nerd, I found really, really interesting and even entertaining. I took some of the measures that were part of Patrick's presentation and part of mine and summarized them here as sort of a lead into our discussion and our report outs by the county. So a couple areas that I'd like to highlight here were some measures that were socio-determinant in nature, and as we all know, socioeconomic factors very likely impact overall health outcomes, such as premature mortality and lifespan. You might even say that human longevity is a side effect of our health and our social circumstance. So some of the measures that we have here include families with children that are headed by a single parent, so single parent households. Overall, the GCACH average is higher than the state average. As well, median household incomes for the GCACH are lower than the state average. And in particular, household incomes for Hispanics are considerably lower than the state average, and in some cases by as much as half, which is a cause for concern. As well, all age poverty rates, youth and adults, the overall GCACH average is higher than the Washington state average. So thinking about these, all these indicate poverty level conditions for individuals and family, which might affect individuals' ability to access care and might result in poor health outcomes. Another area that's concerning is the uninsured rate. Since 2013, Central Washington, Eastern Washington, in fact, Washington overall, did a great job in terms of getting people enrolled in the open marketplace, the health benefit exchange, including through Medicaid expansion across the state of Washington. I was part of that experience, and they had some great gains. That said, in Franklin and Yakima counties, there's still a considerably large population of individuals who are still uninsured. And this might indicate the presence of large populations that are frankly ineligible for any type of health insurance coverage simply because of their immigration status. Luckily, we have quite a few federally qualified healthcare facilities, community health centers that serve those individuals. So making sure that those individuals have access to that particular type of care is really important. Food insecurity, this is another issue that's particularly prevalent in our smaller counties, Stoughton, Columbia, Garfield, Kittitas, Whitman. You would think, you know, being sort of a breadbasket in terms of agricultural, there'd be an abundance of food, and yet some of these smaller communities do struggle with food insecurity in terms of having the availability of fresh food. Another issue, which is an overall health outcome measure, premature death rates. This is particularly prevalent in Columbia County and extremely prevalent in Yakima, which I'll talk about in just a minute. Another area that is of importance to us relates to obesity and diabetes. Obviously, those two areas are interlinked together. This also ties to poor access to healthy foods and really fewer opportunities for exercise. Some of this could be addressed through policy changes, such as putting in walking paths or parks. Obviously, a lot of this relates to lifestyle as well in terms of self-motivation to exercise and to have a healthy diet. The next issue relates to sexually transmitted infections, which are measured through chlamydia and gonorrhea rates. This is something that's particularly important, and it's part of a national trend where STIs have increased overall. Part of this has been attributed to social media. It's of concern because some of these conditions or infections potentially can lead to cancer, and for gonorrhea, for example, they can lead to antibiotic-resistant infections, which are very difficult to treat. So a number of our counties have high STI rates, and in fact, Whitman County has the highest STI rate in the entire state. This is probably attributable to the fact that that's a predominantly college-age population. Another issue are teen birth rates, and this is, again, particularly prevalent among Hispanics. In the most recent release of the Robert Wood Johnson Foundation County Health Rankings, they did a great job of teasing out subpopulations by race and ethnicity, so we can see for some very important measures the rates for certain statistics around teen births, and it points that Hispanics have and traditionally have had high teen births, and this is particularly true in the Stoughton, Franklin, and Yakima counties, where there are, in those last two counties, there's a high degree or a high prevalence or percentage of Hispanic individuals. And finally, for this first slide, as we all know, we live in a provider shortage area, primary care, dental care, and in some cases, in particularly behavioral health care. There are shortages of providers. The Greater Columbia has taken on an initiative to support a behavioral internship program, which we hope will address that last specialty area. Chelsea, if you could go on to the next slide. So some things that are of interest here. Last time we looked at some statistics that related to the American Indian Alaska Native population in Yakima, which counts as being around more than 16,000 individuals. And some statistics really jumped out of that data set. Going back into it, I teased out some additional information. We compared Yakima County's statistics against statistics from across the state for injury, death, child mortality, motor vehicle crash deaths, homicide, firearm fatalities. And for all those particular measures for that particular subpopulation, the American Indian Alaska Natives within Yakima County, they had the highest rates of any subpopulation in the entire state. And that was at the county level and the subpopulation level for race and ethnicity. And in some cases, that was more than 100 measures for each one of those rates. And tied to this, and not surprisingly, the American Indian Alaska Native subpopulation within Yakima County has the highest premature death rate, not only in the entire state of Washington, but also it has one of the highest premature death rates in the entire nation. I went through and I looked at all 50 states, and I looked at every subpopulation within every county within each of those 50 states. So I went through probably 5,000 or 6,000 statistics, and out of that, the premature death rate for American Indians and Alaska Natives is one of the top 20 in the entire nation. So that's a really great cause for concern. What I will say last year relates to something that we identified in the last go-around, which relates to what we call the Hispanic paradox and the barrio advantage. Hispanic populations across the GCACH experience lower median household income, higher childhood poverty rates, higher teen birth rates, and lower access to some types of preventive care. Now, we would assume, based on our assumptions between the relationships of socioeconomics and health, that this would lead to higher premature death rates. And in fact, just the opposite is true. Paradoxically, the Hispanic subpopulation tends to have lower premature death rates and longer life expectancies. This has been termed the Hispanic paradox. In part, this is explained because whites have higher rates of injury, death, drug overdose, suicide, smoking, childhood mortality, and more. And the fact that family ties amongst Latinos tend to be stronger, and it helps build a sense of community. These are resilient factors. It contributes to better health. And this is especially true for mental health. Unfortunately, this is not all good news. The Hispanic subpopulation does tend to have higher rates of obesity. They also face more limited access to health services and health insurance coverage. As well, second and third generation Latinos that are born and raised here tend to lose some of the advantage, which has been termed the barrio advantage or barrio effect. So just some things to think about in terms of where that subpopulation is at and some areas that we can carry out in our work to improve overall health. And I'm going to stop there.
So quick questions of this tremendous summary that's before you. A lot of moving parts beneath those bullet points. But we could take a little bit of time if somebody has questions on one or more of them. Wes, I think.
Well, this is Ronnie Batchelor.
Good morning.
Good morning. Hope that you're safe and staying safe.
You as well, thank you.
The question I have for this, working extensively in the Hispanic community for healthcare and assistance, could this possibly be related to the fear factor that comes in with the alien aspect of not being legal in the United States, and then that go through the generational, because if you have one person or both parents that are not legal in the United States, that bleeds over into the next generation, and the fear factor of that as far as health care or community assistance.
Well, you know, there may be some micro trauma that occurs for individuals that migrate into this country and experience some of that that behavioral, you know, that mental distress. However, the data tends to show that that protective factor that's conferred upon communities that come together, the Latino communities that build these strong family ties, that resilience, you know, sort of sharing the work and helping each other actually contributes to better mental health. So I would say that that stress that might be endured, as long as those individuals come together in communities and neighborhoods, there's a counterbalancing effect to provide protective factors.
Thank you, Wes. One more question. Do we have another question? And then we'll have to probably shove on. All right. Wes, you may be off the hook.
Thank you.
It's fair to say, Chelsea, Lauren, who's ever in charge of this, that this information will be on the ACH's website going forward. Hello.
Yes, that's correct.
Thank you.
Yes, Patrick, this is Lauren. It will be posted on our website.
Very good. Okay, so people can review it there. And I think this next presentation will be on the website as well. So Chelsea, if you wouldn't mind bringing that up. This is something that I put together over the last day or two. And it's just an attempt to try to get a sense of what the data are telling us about COVID-19 in the 9 counties that make up the ACH. And then basically, if you go to the next slide, this will tee up, I hope, the ensuing reports from the field, and perhaps be able to offer some reinforcement to what's being said by the various experts that are about ready to come online here. So my source of information here is the very, I think, well done section on the Department of Health website, which I check probably too many times per day to see how we're flattening the curve, statewide anyway. And just let me say that what I'm going to do is look at county by county and then provide a summary of some of the indicators that I've used to present this. But I'll give you the punchline now and not at the end, a little bit of a twist. And the punchline is that there's a big difference between the manifestations of COVID-19 in the ACH, depending on whether you're a large county or a small county. And then a second punchline, I can't confirm this because it's just statewide data, but there seems to be quite a bit of difference in the prevalence of COVID-19 among Latino, Latinx residents of the county or of the state, which I presume would apply to the 9 counties that make up the ACH and all other racial and ethnic groups. That's for confirmed cases, but as you'll see, but thankfully, it's not the case for deaths from COVID-19. Okay, so let's just shove on to the first county that I've highlighted. This is Kittitas, and I'm going to go from northwest to southeast, and I hope you can see this well enough on your screens. But this is a county so far that has largely ducked the outbreak of the virus. As of Monday night midnight, and this is when the data are taken from, there were only 14 cases, thankfully, out of 549 tests. That was a positive ratio of 2.6%. So as you'll see here shortly, quite low, and very thankfully, to date, no deaths. So hopefully we'll have some comments from Kittitas as we get into the presentations about why that might be the case. Next slide, please. Yakima is a different story. I think as many of us know that. We have a total of, as of Monday night, midnight, 614 cases that were positive out of 3,550 tests. That's a positive percent ratio, or positive ratio of about 17%, which is quite high, as you'll see, and the death total of 25. So just think of that juxtaposition between two counties that very often are treated together jurisdictionally, and yet we have really a tale of two counties between Kittitas and Yakima. Okay, let's move on then, if we may. Benton. Benton, I think, as many of you know, has had a fairly high outbreak of COVID-19. Total confirmed cases, 265 out of about 1,600 that have been tested, for a total of 29 deaths. And I know this has gone up, unfortunately, in the last day or two, but a percent positive ratio that's very close to Yakima, 17%. And I know we'll hear more about what lies behind these numbers, and so I won't spend any more time to decipher them. Okay, across the river to Franklin County, if we can go there, Chelsea. Here, not nearly as many cases. Of course, the population is less. Total tests were 583, but the percent positive ratio is the highest of all the 9 counties in the ACH at close to 24%. And I might add, from just my quick perusal of the DOH website, this is the highest prevalence rate of positive cases in the state, except for one county, which is the county due north of it, and that would be Adams County. As of Monday night, midnight, there were 2 deaths, and I think this has also gone up by at least 1 death. So a much different story between well, no, I'll just stop there, and we get into Walla Walla, and you'll see that that's a much different story. So let's go to Walla Walla. Keep moving to the east. Walla Walla has had only 23 cases out of a total of 900 tests, and much like Kittitas County, it's had a very, very low positive rate of 2.5%. And thankfully, as of Monday night, there were 0 deaths. So 2 counties right next to each other, Walla Walla and Franklin, and really 2 different outcomes. Okay, let's go just march across the southeast then, the southeast corner. Columbia County, 1 confirmed case out of 50 tested, 0 deaths. That's fabulous. Like Walla Walla, the positive test rate is extremely low. But there's only been 50 tested, and certainly we know there's only 4,000 people, so that has a role, but we'll just see what that rate of testing is, which is a pretty critical ratio if epidemiologists are to assess just whether we have a correct assessment of the flattening of the curve statewide, and certainly in our 9 counties. Okay, so very little there. And next county, please. Garfield, thankfully, is the only county without a reported incident, without a confirmed case. However, there have only been 14 folks tested in Garfield County, but it is a small county. So we'll see just how many more we'll be able to test, and perhaps Martha or somebody from Garfield or that area can inform us as we go forward. about the likely interaction or the likely initiatives by our public health efforts. Okay, two more then, before I get to the summary. Asotin. And Asotin County has had only 6 confirmed cases. That's a percentage of those tested of a little higher than some of our lowest counties, but still quite low, 6.3%. Again, only 95 people tested so far, and there are a lot of people yet to be tested. Let me just put it that way in Asotin County, if we had the resources. And last but not least, Whitman. As we move up north of Asotin County, we can go to Whitman, please. And here you have it, 11 confirmed cases, also 0 deaths out of 340 folks tested. Also a very, very low ratio of positives to the number of people taking the test. So again, quite a different story, whether you're a small rural community or whether you're not. And so if we go to the next slide, this is a summary of just looking at how many tests have been able to get out there to our populations. And you can see that for the state of Washington, which is the dotted green line, we've been able to test, and this is as of a couple days ago, about 16 people out of 1,000 residents, or 1.6 people, close to 2 out of every 100. And you can see that for our counties, none of the counties matches that state effort. And so things could be different if we had more testing among the various counties that are part of the ACH. You can see that Walla Walla has tested the most, at pretty close to the state average, pushing 15 folks per 1,000. On the other hand, Asotin has tested very few people at four folks per 1,000, which is about a quarter of what the state average is. So before drawing any conclusions about the prevalence population-wise in our counties, we probably need to at least get to the state level of testing and hopefully beyond. And I know there's lots of plans to do this from Washington's Department of Health, and perhaps we'll have some report out to that. Okay, let's go on to the next slide then. Again, summarizing the 9 counties. Here we have those confirmed cases, and you can see it's really a tale of two counties, actually 3 counties, versus everyone else. Yakima at 614 as of 2 days ago, the Tri-Cities at 403 confirmed cases, and then everybody else. So I'm sure there are reasons for that, which we'll hopefully hear shortly. Next slide, please. Now, this is just looking at that positive share of those who have been tested. And you can see the state average is close to 9%, 8.7%. And most of the counties fall well below that. But we have 2 counties, as I've pointed out already, which are quite high. Benton and Franklin, close to 19%, and then Yakima at 17%. So more than double in the case of Benton and Franklin, the state incidence of the COVID-19 virus for those who have been tested. Again, population-wise, in some sort of a random sample, we don't know. I'm sure that those being tested are those that, and I'm Dr. Pearson, you can weigh in here if you'd like. Those who have been tested are those that health authorities have strong belief, a strong presumption that they need to be tested. And we have one more graph slide, I think, if you'd mind moving to that one, Chelsea. And then here's the death count due to COVID-19. Again, it's all in 3 counties. And I know the Benton Franklin count has gone up. I don't believe Yakima went up in the intervening couple days, but For the rest of the county, 0. And that's just terrific to see those zeros across that axis, on the graph. But nonetheless, we're looking at quite a bit more double digits in Benton and Franklin counties. Okay, one more slide and I'll be done, and we can go on to the report from the field. Now, I did want to point this out, and this is interesting in that it ties into some of the work that Wes has done on the socioeconomic determinants of health with respect to Latinos. And this is looking at statewide numbers, and I'll just walk you through the first set of columns on the left here. Again, this is as of a couple of days ago. And this is looking at the population shares in gray. So 68% of the population in the state of Washington is non-Hispanic white. 13% is Hispanic of any race, and you can go on to Asians, African Americans, multiracial, and so on. Native Americans, Alaska Natives on the far right. What you see, though, is a difference in those first two sets of columns between confirmed cases and the share of the population. So that in the white population, the share of the confirmed cases has been 56%, whereas the population share that they have is 68%. So disproportionately low for non-Hispanic whites. And that's just flipped when we get to Hispanics. We have 13% of the population accounted for by this group, and yet their share of those with a positive diagnosis is almost twice as high as their share of the population. So that could be one of the main reasons we're seeing those disproportionate results in Yakima County and then the Tri-Cities, but I know there are other reasons. That's it for my data presentation. Do I have another slide? I can't recall. Could you forward that, I think, to the next slide, Chelsea? I think I'm done. Yep. Okay, so any quick questions from that scan of the Department of Health data?
Patrick, this is Carol Moser. Thank you for your presentation. This has been super enlightening. Of course, I think the big question that we all have is like, so who makes the decision about the testing, and is it a function of a lack of resources to do the testing with? And maybe this is a question for Dr. Person, especially since these statistics really concentrate in the Benton, Franklin, and Yakima areas.
I don't know the answer to that, who gets tested and how they get tested. I alluded to my general notion that there, from what I've been observing in Spokane and certainly reading, that those folks who appear to present with symptoms or something like symptoms get tested, and the general population doesn't. But I don't know if
There's some notes in the chat
anybody
box
wants
about
to
this.
weigh in about that.
There's some notes in the chat box.
Thank you, Wes. Patrick, I was just going to note there's quite a few comments in the chat box right now. I don't know if you were able to see those, but it looks like Amy Person did answer the question.
I'm sorry, I was muted. Okay, so Kevin, thank you for that. The correlation, right? Kevin. Okay, so Kevin, I don't know if you want to weigh in here. We got facility testing. I know that's happening in several counties.
I think Dr. Person had the better answer.
Okay, Dr. Person, do you want to just weigh in here? Dr. Person, maybe she stepped away. Does testing data, does that factor in the clinics who are using private labs? To the best of my knowledge, that does. Any response to that from other folks?
Yes.
That's what I thought. And I think we're seeing more of that all the time.
It's Amy. It took me a little while to get unmuted.
Who's that?
Amy Person.
Oh, Amy, would you like to just elaborate on your chat comment?
Sure. I mean, what we've seen in our area anyway is, yeah, who can get tested, because the criteria for that sort of have changed over time. There has been a lot of variation, and the biggest problem we've had in Benton and Franklin counties is that there, for a long time, a lot of clinics, especially, they didn't have supplies for testing because they did not routinely do specimen collection in their offices prior to COVID-19, so they didn't have the NP swabs or the viral transport media, and of course trying to get more of it when everybody else was trying to get more of it varied quite a bit. When I give my update on Benton and Franklin counties, I will discuss some of why I think our rates look very different, but because that I think is not so much related to testing. Right now, anybody, any provider can choose to test someone. I think there's a lot of variation in how that's being done. There are some areas where we're seeing more testing of asymptomatic contacts, and there are other areas that are still primarily only testing people who are symptomatic. So there really is a lot of variation. Some of this data hard to compare.
Okay, well, thank you. I think that's very true. And we have a comment from Mary Dye. I don't know if you want to speak up here, Mary, that tests are being rationed, and sounds like it's a similar response to Dr. Persons, but rationing is only to folks in the hospital, although that's changing, we're saying.
Right. So we have a state line problem where the larger population in Lewiston and Clarkston is in Lewiston. And so the way that our state triages communities has allocated 500 tests to that whole valley. A lot of the Lewiston residents seek treatment in Tri-State Hospital. They only test the people that are hospitalized with COVID-like symptoms, and then they take the test, and they've been sending those tests to pathologist regional lab in Idaho. So then you have that cross-state determination. I don't know how our triage and our Department of Health is looking at those results, because the website hasn't changed for a week and a half on noting Asotin counties. And I brought that to the attention of Senator Winder over in Idaho, and he took it to Governor Little. And Governor Little was to be working with Governor Inslee on the issue to try and work that out. So this week, Governor Little has gotten the attention and sent a bunch of testing equipment and tests down to Lewiston. And we're seeing a real big increase in identification of COVID in that valley, but we still aren't recognizing that in our system. I received the phone call from Tri-State that they'd had 2 deaths. One was from Life Care Center, which is just north of North 40 on 21st in Thane in Lewiston. So we're not getting that documentation that they actually did have 2 deaths at Tri-State Hospital. And so I'm really questioning what's going on down there. And I think it would be nice if we could get some of our people to, draw attention to the fact that we're still not getting testing. I talked to Scott Adams at Pullman, and he said that they're going to a different lab and getting their results back in 2 days. And again, they're limited on testing. And when I spoke to Garfield County Hospital yesterday, they said they only had 3 test kits in inventory, that they had applied for some PPE protection for their first responders, their sheriffs, and the order went in, and then it wasn't on back order, it was actually dropped. So they're not getting any PPE either. And so when you have a hospitalized patient for 7 days and then get your test result, that means you have to burn up PPE for 7 days before you get a positive or a negative. And so these are some of the issues in our little corner of the state that I feel like the system itself is totally ignoring. And obviously you have to match number of tests to the population and say, is that an apple or an orange when you're comparing to these other high incident counties like Yakima?
So if I may, I've been doing a lot of work with the Ready Coalition around this and with Vice Admiral Bono. I can't say I'm working directly with her. I've had contact, but what I'm hearing from the state is if you make known to the state's response team that you have a case in a nursing home, they're going to help you test everybody in that nursing home, and you will move this up the food chain.
That's good. That's good to know,
Right.
Kevin.
And that's the thing, is the nursing home that has the infection is in Idaho, and the death from the nursing home occurred in Washington. And so, you know, they hospitalized them at the Tri-State Hospital instead of St. Joseph's Regional. And so you have this cross-border problem, and the data isn't crossing fluidly across the border as well as the patients are.
Yeah, that's Representative Dye. That is an issue with border communities, and I'm happy to hear that you have engaged the help of the Idaho authorities, including the governor. Let's see what happens. Are there other counties that are facing what Representative Dye just talked about, which is a shortage of tests? So by that silence, I take it that most counties on the line feel like they're able to get most of the testing that they think is important done.
I think it's closer to say, and this is Kevin Mark again, at least here, we've balanced our needs against the available supply. We have plans for what happens when we have our first case in a nursing home. But are we able to do surveillance level testing? No, nobody is. So while it isn't as dire as the rationing we just heard described for most of us, we are being pretty stringent in how we prioritize. And this is the point I made in the chat earlier. Given what we know about how much asymptomatic carriage there is, most of us for a long time were only testing symptomatic individuals or individuals with known exposure. That's loosened up as the supply of testing has gotten better. Currently, the state lab and LabCorp are both running about 36 to 48 hour turnaround in our experience. That only counts if you can get a swab to them. But in a perfect world, we would be doing surveillance at this point. We would be trying to figure out what the actual epidemiology of this infection is. There's a report of the aircraft carrier Theodore Roosevelt, where of the individuals who were infected on the ship, which was something on the order of 600, at least half of them were completely asymptomatic throughout the course of their infection. And if that's true in the rest of the world, that would explain a lot of the transmission that we haven't been able to explain. It's also not necessarily bad news. If half the people who get this infection, it resolves without any complication, that could mean that there's a lot more herd immunity already than what we have, than what we suspect. If most people get exposed to this virus and nothing happens, we could have a lot of people who are not vulnerable.
That's,
but you know,
great news, Dr. Martin.
Well, the underlying issue is the testing that I've heard promised for 3 weeks still isn't here. We still can't test everyone.
Right. Okay. Thank you. Thank you for that comment. And before we shove on, Rhonda, do you have anything to report from Yakima? I know you put something in the chat box.
Yeah, I was, Dr. Martin just sort of said a piece of what I was going to say in that, I think we're all rationing. I mean, we are prioritizing. And I think one of the things that is helpful here in Yakima is that we are talking with, we talk on a regular basis, weekly, with the other community health centers and with the hospital about who we're prioritizing. And so we are really coordinating that effort. And so I think at the community level, people understand we're really testing people who are symptomatic, and there is a heightened focus on people in the long-term care facilities. And I don't know if anybody is on the call from Community Health of Central Washington. They are overseeing the majority of the long-term the nursing homes and really have their hands full. But we get a lot of requests for people that are asymptomatic that want to be tested, and that's a good thing because there is an awareness. I know in our sites, we have been seeing, more activity in our lower valley and the more rural sites than here in Yakima. And that probably goes to a higher proportion of the Hispanic population. But I think it's helpful the fact that we are more in sync in terms of who we're prioritizing just at the community level. So but I think it would be when we are at a point where we can open up to who we're testing to more asymptomatic patients. I think that's really where we want to be. We're also looking at some of our congregate housing facilities and how we approach our residents there, because that, again, probably second only to nursing homes, we have some very vulnerable residents in our permanent supportive housing units that we're concerned about as well. But again, they have to be symptomatic before we can test them. Thanks.
Thank you, Rhonda.
Patrick, this is Carol.
Yeah.
Yeah, sorry. In the end, though, we received a map yesterday of some of the resources that are being distributed across the state. And it was disturbing to me. I sent you a copy of that map. We're trying to get to the bottom of the disparate resource allocation, but unless you have some resources and some PPEs to begin with, you can't do the testing. Now, I don't know, I'm hoping that Dr. Person is going to talk about testing in Benton and Franklin counties, because every time I read the paper, there is mention of a lack of testing equipment. So perhaps she'll be able to cover that when she talks. But I just think that the resource allocation the algorithm is a little bit messed up, has been historically, and hopefully we'll get some questions from the Department of Health regarding that resource allocation map.
Thank you, Carol. You might want to share that with Representative Dye, because I think it in part answers her concerns about the PPE scarcity that she's observing. So
I'd love to. Thank you. And thank you, Representative Dye, for joining us this morning.
Les, I don't know the answer to that. Les Stallnecker had just posted a chat comment that he said, I understand the data are based on residence and not location when the person is tested. Dr. Person or Kevin, could you weigh in on that one? I don't know.
It's part of the reason that the numbers shift is DOH examines where initially they tend to assign it where the test was done. So that's why at one point there was a death attributed to Kittitas County that was actually somebody who had spent most of their life here, but the last months of their lives were spent in a care facility in King County, so that death was moved to King County. And that adjustment is going on continuously, and that's why at the bottom of the state table there's usually a row of unassigned. Those are the people that are trying to figure out where they belong. That's correct. If the test is done in Idaho and the result never makes it to the Washington Department of Health, they don't have that data to sift.
Got it. Okay, thank you for that clarification. Okay, well, we've had a good good discussion so far, and I hope this is a harbinger of what's going to happen now as we move into the updates from the counties. And as you can see on your agenda, we have a cousin of mine, no, just teasing, Shannon Jones from Asotin County. Are you on the line?
I am, yep.
All right, would you mind just telling us a little more detail? We've talked about Asotin a little bit, but let's talk about it some more.
You bet. I'd be happy for you to be your cousin of mine. So, Asotin County, as you know, is a small county. Our office is about up to six people, usually no more than that. You can see just from this chart, the focus is COVID. It's taking up about 41% of our staff hours, or 2.19 FTEs out of the whopping 5.5 that we have. So our focus has really just been on that effort. We are doing case tracing within our office. We were partnered to go with DOH to get that help, but that has not been received. So we are kind of going solo, and our administrator is handling most of those calls at this time. I won't take a long time on my slides, so if we can go to the next one. This is really busy, but it kind of puts it in a nutshell. These are the efforts that we have made in the past 60 days. We couldn't do it without our partners. They're listed in blue. I won't go through those, but they're listed. The issues have been what have been stated already. There's the PPEs, the ordering and the dissemination of those. We did actually receive a large shipment in late last week, and it is being disseminated as of yesterday and today. Will be out to tri-state and long-term care facilities, etc. That's being done as we speak. The testing kits have been lacking, and we received several of those at this point. And we have 9 confirmed cases as of yesterday, 10 as of this morning, and 2 possibles at this point. So we are increasing by the day. I guess some of our challenges were, the communication amongst all of these individuals. This is really new to us, and then the resources that it took for us to get going, and then what was going to be not done so that we could accommodate this effort was a challenge for us. So we're in constant meetings, chats, etc. with our partners, figuring out who's going to do what. The stay home, stay safe compliance has been a bit of a nightmare for Asotin County. We have, after getting us all home to work from home and closing the office to the public, which was a bit of a setup process. We've had a real challenge with some of the local contractors in discontinuing their jobs, defining who's essential and who isn't, what projects are essential and which aren't. We've had an emergency board meeting in regards to that, and another one again this afternoon. It serves to be a challenge because one of our cases actually came from Spokane. He was a positive COVID and went to the long-term care facility to work on that project to add on a wing. So obviously we have some high levels of concern there. And then just establishing the workflows that are required with a remote workforce can be a challenge. We have a lot of demands on our time for TV and radio communication. We've come up with a process to kind of tailor that back, and we go to them. We try to we let them know that we will go to them and make sure that we're communicating with them, but the hundreds of phone calls is not a productive way to go about it. We're trying to update our website as things progress throughout the day, and we're trying to keep our social media updates in conjunction with those website updates. Again, our enforcement has been an issue. The educational visits that we have throughout our communities are causing some disgruntled people to reach out to higher levels, i.e. the governor's office, LNI, etc., and including some attorneys. So we're dealing with those ramifications. Hopefully today's meeting will bring us some resolve, but that's yet to be seen. We did receive the emergency grant housing from the Department of Commerce. We have secured up to 25 beds with our partner Quality Inn and Suites. We put our first person in last night. We wish that would be taken advantage of more. We've communicated it to all of our partners, and we have all of the services, or working on getting all of the services in place to accommodate those stays. So that's kind of where we're at there. The other question was, what are our challenges and unaddressed lacking areas? And it's, I'm sure this goes across the board with everyone, and that's, the funds that are needed to handle the situation, PPE. I'm on the next slide, by the way. The testing. Brady wanted to let everybody know that we were in a mode of only hospitalized and medical care workers were being tested. They have opened that up now. They have developed a tier level. And I believe it's 3 to 4 tiers is what Brady was explaining. And they're testing all the way down now to the 3rd tier. So that's good news. And I think that's one of the reasons we are seeing an overnight shift in some of the cases and the increases. And then our challenge is the not having clear, concise, and consistent policy directions and expectations from top down. We've run into, depending on who you're talking with, we get a different road to travel, and that can be challenging. A lot of it can be handled on a local level, but they're not quite sure what the interpretation is of the order as well. So there's just a lot of confusion, and from confusion, frustration. And then where do we go from here? Really, there's a huge concern with kids and families and the mental health that goes along with issues that go along with this type of care behavior. We have a lot of people reaching out and phone calls coming in on suicide prevention, lack of resources at home, those kinds of things that our public health educators trying to deal with as well.
Right. Thank you. Thank you, Shannon. We have time for a couple quick questions of what's going on in Asotin County.
Yeah, this is Wes. Shannon, that was a great presentation. Thank you. I have a question. You were talking about some current legal pushback that's occurring. Is that occurring from residents or businesses, or a combination of both that are pushing back against the stay in shelter? Or can you elaborate a little bit more about that?
Sure. We have, hang on just one second. Please forgive me. We have a particular contractor who is building a facility for VPA, and he has been told to discontinue, cease and desist by Department of Labor and Industries and by the governor's office, and he has chosen not to comply. So we have been served, the health district has been served an anti-harassment charge that if we are not to address him anymore or to try to get him to comply to the order at this time. So, and that came from, unfortunately, the city attorney.
Thank you.
You're welcome.
Real quickly, from anybody else on the line, are you facing any difficult cases like this of compliance, and even escalating up to the legal realm, or is this just Asotin County's unfortunate lot? Well, Shannon, looks like you might be a pioneer in this situation, I should say.
All right. Thanks, everybody.
Okay.
Hey, Patrick.
Yes, is this Ronnie?
Yeah, this is Ronnie. So not to disclose, but I have a couple of clients that I'm working with, and their bosses, even though they're not essential, are making them come to work. And it's more about the money, not about the safety of their people, because there's no masks or anything. And I've encouraged them to go to the Department of Health here or the health district here to report. And unfortunately, they're afraid for their jobs and everything else. So there are threats that are waged towards the workers to keep them afraid. So anyway,
And we're hearing those as well and addressing those with some of the departments.
yeah. So the only thing I can do is encourage them to report. If they don't report, or if they can't get with their other coworkers to stage a walkout or something of that nature, but they are not essential workers, they're factory workers. So it's not a good, healthy environment for them, unfortunately.
Okay. Well, that's unfortunate to hear. Maybe other communities have not experienced that, thank goodness, but that's too bad. All right, let's move on to a little bit to the west of Asotin and hear from Martha, representing Garfield and Columbia counties.
Good morning, everyone. Glad to be here. First, I'd like to talk about Southeast Western Health Network that covers all 3 counties. We did a couple of things right away when COVID-19 started. One was we ordered some Logitech meeting and Zoom subscriptions. Ended up with 1 in each of the public health departments that our Southeast Western Health partners could use, and then set up Zoom accounts connected with that again for our partners. And then we ordered an additional 1 to be left at Garfield County Hospital because they didn't have one. Columbia and Asotin County were already set up in that area, so we didn't put 1 there. In addition to that, with group health, I reached out to them early on to see if there would be any funding there, and they have awarded an additional $100,000 to Asotin, Garfield, and Columbia County for COVID-19 related activities. So each of the counties will, the board agreed for each of the counties to get money. $40,000 is going to Asotin, $30,000 to Garfield, and $30,000 to Columbia. And this is for whatever needs arise. We're looking at anything from Chromebooks and for students in Pomeroy to internet access for some people in Columbia County, for school related, to possibly rental assistance, to maybe some school lunch program through the summer. So we haven't decided on any yet, but we have some opportunities there as we go through this. Just a little bit, if you want to go to the next slide, talk a little bit about what we're doing within Columbia County Public Health and Garfield County Public Health. As I travel the 30 miles back and forth, both counties got a housing grant. And so I hired somebody to manage that housing grant in both counties. We've secured 17 beds in Garfield County, and it looks like we're at 20 beds in Columbia County with contracts all done and beds ready to go, and a referral system in place that starts at public health. When somebody gets tested, public health is notified, and then we will ask the questions of whether they need isolation and quarantine and go from there. We immediately set up 2 healthcare meetings in each of the counties every other week. And the healthcare meetings consist of multiple hospital staff, all the way from lab to the nursing home director to EPI to EMS to the sheriff's office, so that everybody could, to the emergency manager, so that everybody could stay on the same page and know where our supplies are, what's our rate of supplies, what policies are changing. As we get the policies in public health and in the hospital, we shared policy changes. And these healthcare meetings help get that information out to the people that are needed to have that. So that those healthcare meetings, I think, are the critical part for us to all stay connected in our small communities as we go along. Policy changes that are made at the Department of Health, some come through public health, some come through the hospital, and it's just important that we all stay on the same page with those, and some come through the emergency manager. So we work together on seeing what those policy changes are and how we can help each other in implementing those, and then the next day they change again. PPE supplies have great emergency managers in both locations that are taking care of the PPE supplies, and the changes not only of tier 1, tier 2 of where we fall on the PPE supplies, but both of them have been great at going out and looking at outsourcing and getting supplies from other places. Limited success in that, but some success no less. With our first case coming early in Columbia County, we got some of the supplies early on that really helped us sustain through. And then last week we got a reasonable supply of N95s that allowed us to share with our healthcare partners in our county and breathe a little bit of fresh air that we won't run out. And that's very helpful. Public messaging is, to me, a critical part of public health, not only within our healthcare system, but out into the public. So we are involved in the food bank and are doing weekly flyers around COVID related activities and mental health, some mental health support out to the food banks. In the school lunches that go home every week, we put some messaging in there. We're doing some social media, and we're also starting today, we are also sending mental health kind of packets and things home with all the Meals on Wheels, the senior citizens, so we can get information out to them. In addition to that, we also do WIC. Food stamps has increased, so we're doing WIC and food stamps and insurance. Both of those are increasing substantially, and so we're doing all those remotely, and they have been very successful in doing all those remotely, and they have somebody in our community to rely on to do that. And then lastly, we just received an Innovia grant from Spokane for $17,000 for Garfield County to help with rent and power bills, utility bills, and $19,000 for Columbia County around rent assistance and power assistance. So we have an economic meeting every week to fill in the economic people on what's happening in the healthcare field, and then I relay that information back to the healthcare meetings to keep everybody on the same page. We are fortunate in Garfield County to not have a case yet. The number one question is, how does that happen? We have people that have been smart. We have 25% of our population in Garfield County are seniors, and we got the messaging out early to them, and they went home and they stayed home. And we're checking on them, and we have both the transportation systems in both of the counties have stepped up and are doing free delivery, home delivery to groceries, free home delivery for medications that are ordered in town. so they don't have a reason to go. We've also set up a volunteer list at both locations. I have them both a nurse volunteer list and a volunteer list of the public that have asked to come and help us if we need help delivering food or delivering groceries to people that are isolated in quarantine, or in case of the nurses, for them to come and help us at public health, do contact management or contact investigation when we need. I have contracted with 2 nurses in Columbia County that have helped when we were up to a reasonable size of people that we were contacting. So that and the weekends, and so that has really helped. So I think that I want to thank Greater Columbia for the contribution to the food bank. I think that's going to really help Garfield and Columbia County, and also for the telehealth equipment that that was put into the mental health in the hospitals so that they continue to do appointments and things with the telehealth. That's going to help both of our healthcare systems in both of our counties. Thank you.
Thank you, Martha. That's a lot going on for 2 small counties. Congratulations. We have maybe time for one quick question of Martha's efforts or of Columbia and Garfield County's efforts? All right. Then let's move on to Whitman. And Jeff, are you on the line from Community Action Center?
Yeah, this is Jeff Guyette. Can you hear me okay?
Yes.
Hey, Patrick, real quick, I'm sorry to interrupt. This is Chelsea. I just want to note that Megan for Walla Walla County has to get off the phone by 10:30. So I just wanted to point that out.
So
Jeff, would you mind?
I'm happy to defer.
Going back to being on deck, and we'll put Megan at the plate.
I am so happy to do that. You bet.
Okay, thanks so much. All right, Megan, take it away. Why is Walla Walla seeing such success with the statistics I presented?
Well, I think, good morning, and thanks, Jeff. And sorry, I have to get off a little early. But I think that there's a lot more to all of this than statistics, right? And so Chelsea, you can start at slide 6 and 7, maybe 7 or even 8. Go ahead. But this was a presentation I did last week for Rotary. But looking at where we're at today is we're at 26 cases, and I think it's all about what. In Walla Walla County, at least, similar to Columbia and Garfield counties, we don't have community-based transmission of COVID-19 at this point, largely thanks to the stay home, stay healthy orders from Governor Inslee, and also, because our residents have been very diligent if they are being tested. I mean, we've had over 1,000, about 1,300 residents tested for coronavirus to date. And when they're tested, they need, they're going home and staying under isolation until they receive their test results back. And so they're being very diligent about that, and that's really great. And I think when this all started, Walla Walla County is in Providence, St. Mary's Medical Center is a Ebola assessment hospital, and so we work with Providence a lot as it relates to special pathogens, and COVID-19 is considered a special pathogen, and so we already have a lot of work done with the healthcare system to prepare for this and respond. And I think in Walla Walla County, something that's interesting, is actually a lot of the cases that are presenting here, or at least about a third of them, are not even Walla Walla County residents. The 26 cases that we have are, however, Providence and Walla Walla Clinic and Family Medical Center, all of our healthcare providers here are also treating a lot of Umatilla County residents. And so we have that state line to play with, and that's been really interesting. But I think we're lucky that, I used to be the health administrator for Umatilla County, so we have some good partnerships there. really what our operations hub looks like moving forward is doing a lot of specimen collection and shipping. We're monitoring all people or persons under investigation and tracking, the case investigations, contact notification. Those have been our large focus areas, because that's really how, we maintain a handle on COVID-19 within our communities, is early case identification and isolation of those individuals, and then immediate contact notification for any of their close contacts. And then we've been doing a lot of education and outreach to our community, as with, we have a pretty robust community response here in Walla Walla County, because we're kind of similar to what Martha was talking about. Not only are, we're a public health and human services entity, so all of those human services funds and contracts flow through us as well. So it's nice to have everything under one roof, but it's also really exhausting. I think one of our huge successes in Walla Walla County, Chelsea, if you could go to the next slide, is our unified command. And immediately we set up shop with our emergency management department, and then all of the cities within Walla Walla County declared a state of emergency as well. And so we have each city represented on our unified command, and as with the port and as with Providence and our commissioners and the VA, long-term care. We have one long-term care representative that actually, Ben Flinders with Park Manor, he has a weekly call with the other long-term care representatives in our county, and so he represents there. And we also have, the governor's office, and you can see this whole list of everyone. But we've been trying, we meet every day at 9 actually, and so I missed that call today to be on this one. But we have a good team who's being very responsive and making sure that we're getting all of our, a lot of the ordering that you guys were talking about earlier, whether it's test kits or PPE or whatever else, all goes through emergency management. And while that's a very complicated and convoluted process, our emergency management department actually understands it really well. And so it's been really nice to just say, call emergency management if you need something, and they've been really on top of it. I mean, we have a small emergency management department, not as small as others, but it's a two-person team here in Walla Walla County. But they've been really great partners. And Liz Jesse, our emergency manager, is actually our PIO, and so she's been taking the brunt of a lot of our communication requests and especially things related to Tyson as of recent. And so if you could, Chelsea, if you could just go to slide 11, which I think is 2 slides away, or maybe 1 slide back, sorry. So something that we started, this education and outreach. And so when we had our first case in Walla Walla County, even though it wasn't a Walla Walla County case, the Umatilla County case that presented here to our hospital, we knew that we were going to get a lot of calls. And I think that's something that's probably similar within a lot of communities. People, are humans, and they want to talk to a person. They don't want to sit on a hotline, or, a call line at Department of Health or call 211. They want to talk to a person. They want to talk to a local person. And so we've set up a hotline that runs Monday through Friday, 8 to 5, and our staff take different shifts on that. And we've compiled a good frequently asked questions. A lot of them are similar to questions that we're, getting, at the state level and things too. And then, with our public information officer, and we're working, our county's website is kind of difficult to use. And so we've worked with the city of Walla Walla to make a more robust website. And we've got a pretty good social media presence. And then we're working, yesterday, I don't know if anybody follows us on Facebook, where you would have seen our first, I don't think everybody's on necessarily. And so you would have seen one of our first PSAs coming out, working with CM Bell, who's a really produces really beautiful work. But we'll have a series of public service announcements coming out, and some interviews with community members and restaurant owners and things like that coming out over the next 2 weeks. That'll be a lot of fun. to work on. But yesterday's PSA that came out was specific to what we're doing in partnership with Benton Franklin Health District. And so, Dr. Person, if you're on, thank you so much. And Department of Health and working with Tyson. I'm sure many of you have read the news or watched the news, and Tyson is a much larger issue than just the Wallula Pasco plant. However, we have to date 50 employees who have tested positive at Tyson, and so most of those actually live in Benton or Franklin counties. 6 live in Walla Walla County, and 1 lives in Umatilla County. And so we have a multi-county outbreak there at the Tyson meat processing plant. And a group of Dr. Yucca and I and a couple of our team went out there on Monday, which was fascinating. I don't know if anybody's ever been to Tyson, but I don't recommend it, especially unless you want to become a vegetarian. Luckily, I already am, and so things were okay. But you know, we understand that it's multifaceted. It's not as easy just to close them. But we're trying to work with Tyson, and I have a call actually with them at 10:30 with Tyson Corporate to talk about what's going to be required of them to put in place by next Monday if they want to remain open. And so I think that what Tyson's struggling with right now, not that it's an excuse, but that they have plants throughout the country, and every state has a little bit different requirements. Washington State probably has some of the most strict requirements, and they aren't necessarily up to speed on those. You know, they have a COVID-19 plan, however, it's not as robust as what it needs to be to continue operating in Washington State. And so not only are we working with Tyson, but we're working with several other large employers in Walla Walla County, whether it's First Fruits up in the Prescott area or Americold. I mean, we're pretty much working with every large employer in Walla Walla County who is currently open to make sure that they're operating in a safe and healthy way to protect their workers, and ultimately to protect our broader community, because we know that it's either one of those large employers or a long-term care facility where we're going to have a hot spot and end up having some elevated risk of community transmission. And so Chelsea, if you could go to the next slide really quick, you can see really what our community response has been early on, working with schools, all 3 colleges in Walla Walla County, and all of our K through 12 schools as well, private and public, and working with them before even school was canceled or school was beginning to be canceled, but to make sure that they had proper preventative measures in place. And we have a pretty robust isolation and quarantine plan, even though we haven't had to use it yet, and we haven't had to do any involuntary isolation orders. And like Soten, we have a very strong plan in place, because as one of our police chiefs said, you know, we can't hope that we won't need to use it. And so we have a pretty robust plan in place, and we're pretty lucky that we have some good community partners who offered some of their space, especially the colleges, because they don't have as many students, and so they have a lot of vacant buildings and houses that they usually have students living in that they offered to us. And so along with that, I'm sure that most of you are aware, at least within the county world, that there is FEMA public assistance available for non-congregate sheltering. And so that's something that will help what Martha was talking about earlier, the commerce funding for the COVID-19 outbreak for isolation and quarantine. It'll help extend some of those dollars, because about 75% of our expenditures as it relates to non-congregate shelter could be reimbursable through FEMA. However long that'll take, who knows how long it'll take to be reimbursed. But of course, we're working with our long-term care facilities, and the homeless planning has been very robust here in Walla Walla County. What our number one goal was for our homeless population to be able to, you know, stay home and stay safe, even though they may not have a permanent shelter. And so what we did is we worked with our shelters to get up to operations at 24/7, and to increase, you know, meal deliveries there, and sanitation options and things like that. So all of our shelters in Walla Walla County now are operating 24/7, and we are lucky that we have only had to test a couple of homeless individuals, but we'll use our isolation and quarantine plan if we need to isolate somebody outside of the shelter setting. I think something that we're really looking at is our long-term recovery plan in Walla Walla County, you know, and that relates not only to, you know, to behavioral health needs, and it's also to businesses and what, you know, what it's going to look like, you know, 3, 4, 5 months, 2 years from now, and how we're going to support our community outside of the, you know, this initial outbreak, and what, you know, what wave 2 is going to look like for our community, as with what long-term recovery, and it's going to be interesting. You know, I think that, you know, there's a lot of work going on with the state and Governor Inslee's office and Department of Health right now, you know, with are we going to reopen, or when are we going to reopen? And I don't think that, you know, from the public health perspective, we're not ready to reopen anything yet, you know, and I think that's been our big push, you know, is that even though we only have 26 cases, we have 26 cases, and we're a fairly small public health department, and I think that shouldn't be taken lightly, you know, the case count, because regardless of the number of cases a community has, our response still has to be very robust. And so I think that, you know, making sure that we keep these stay home, stay healthy orders, and keep our essential, you know, businesses really working only to what's completely necessary at this point is really critical, so that we can continue to, you know, stay with a flat, you know, have a relatively flat curve or flat line in you know, Walla Walla, Columbia, Garfield, some of these counties that aren't seeing a huge increase in cases, because what it's going to, you know, we're going to see an increase in cases as soon as we let up on some of these mitigation efforts. So that's all that I have. Happy to answer any questions. But, yeah.
Thank you, Megan. We're running a little behind schedule, but let's see if there's one question for Walla Walla's experience.
Well, thanks so much, everybody. Have a great day. Stay home.
Okay.
Stay safe.
Thank you, Megan. All right, well, let's go then back to Whitman County. And Jeff, are you now stepping up to the plate?
You betcha. I'm right here with you.
Okay.
Thank you very much for the opportunity. As most of you know, Whitman County is a very small county in the scope of things, and we also are the home of Washington State University, which means that our population shifts based upon that student population that's with us. And for that reason, I think that's part of the reason why our infection rate has been so low. I'm going to speak more as a social determinants of health perspective rather than a healthcare perspective, because that's who we are. We're a community action center is dealing with food and shelter for low-income residents in Whitman County. And so we've been very involved on a community response to the whole COVID issue. And I just wanted to speak a little bit about what happened early on when the order was given. Our students were away from Washington State University. They were home on spring break or headed home when the order came out. And Washington State reacted very quickly and asked the students to please stay where they were rather than come back to campus. And I think that's really helped to suppress some of that infection count here. Our agency really took a quick look when the order came down. We're considered an essential service because we do provide those food services as well as social service and housing needs. But we realized that we didn't want to create any kind of a opportunity for infection in the staff that could shut the agency down completely. So we split the staff into 2 distinct teams, and we alternated working from home and working in the office so that we would always have a skeleton crew available to do our food work out the door, as well as continuing some of our telephone connection with other services that we provide, such as energy assistance and and some of our housing needs. We also quickly worked with Whitman County and the Department of Commerce sent money down for us to set up the emergency housing for COVID response, and we had 16 beds set up within about a week and a half, 12 in Pullman, as well as 4 more over in Colfax. And gratefully, so far, we've been very over-prepared with those services and haven't had to put anybody in those yet as of today. And because we did have a very community-wide rapid response, I think, and the fact that we are off the beaten track, you really have to be heading to Pullman and Whitman County. We're not along any of the I-90 or I-5 corridors, so that we don't really have that kind of drive-through traffic. So the community spread has been really non-existent here, and folks are really following the stay-home order very well in our community. Because we do provide housing, we have about 180 units of affordable and market housing, as well as some housing for folks with developmental disabilities in the county. We are currently constructing a 56-unit affordable housing, low-income tax credit housing project. That project continues because it is publicly funded. It's the only construction project currently going in Whitman County. And we are seeing that that will be easily filled when we begin to open that up beginning about July or August of this year. I think, thinking about some of the impacts locally, our food insecurity rate here in Whitman County is about 20%. I think that that was the first area where we saw the highest increase in need. And in the first week after the stay-home order and when we began seeing some of the unemployment numbers grow in the county, the demand for food went up about almost double from our normal distribution, which is not that large really in our county. So our pantry is one of several around the county, but we're also the largest in Pullman, and so we went from about 20 or 25 accesses per day that we are open up to about 50 or so on average right now, which for us is kind of like being open for food services during the holiday week, which is our biggest week of the year, having to provide that service pretty much every time we're open. So that has been a demand for our services that's stressed us a bit. And of those visitors to the food bank, we're seeing that about 40% of those are new visitors who have not visited us before. And I think, our state and the Department of Commerce has been very agile in responding and getting funds out to help meet the needs, as well as our community. We have foundations locally, as well as corporate donors who have stepped up and provided us funding to continue our services. And we're very grateful for that. So far, I believe that the funding has pretty much been ahead of the actual need. And so we're doing some work right now to be able to measure what the real felt needs are and the real needs are in the community, so that we can be prepared to begin providing for those needs as they come up. Locally, I think it's pretty important that to note that because of our relationship with the Washington State University campus, local businesses have been impacted greatly, and a lot of businesses have had to close completely. Food businesses are struggling with some difficulty to try to stay open. Community-wide, there's been an effort from Washington State University as well as the local restaurants to develop a fund where folks donate to the fund, and then gift cards are purchased with that funding, and then we distribute those cards out to folks in the community who have food needs. So we're just doing that as part of our food distribution, and that's called Pullman Serves It Forward. It's been a great rallying point for the community, and a place where people feel like they can actually do something in the midst of some of the feeling of helplessness that is experienced in a lot of the counties. And we're really grateful for that community partnership to make that happen. I wanted to just kind of depart from facts and figures and there's so much that I could share in terms of what's coming through our doors and what's being asked of us as an agency. But I wanted to tell a brief story about, and that maybe kind of illustrates some of the cross-county and cross-state issues that were mentioned earlier on the call from Masoton County particularly. About half of our staff do not work or do not live in the Pullman area, even though our office is in Pullman in Whitman County. And in fact, we had one of our employees on one of our teams come to work with COVID-like symptoms. It was kind of a foolish thing to do, but they had done that. And so that team ended up having to self-quarantine until we could get some kind of an idea of whether or not it was actually a COVID infection. So that because that person lived in Masoton County and they went to try to get tested, they were refused. And basically, and I totally understand the situation in Masoton County and why that would be the case. So we were able to work with our public health director and the emergency operations center director, Troy Henderson, who, by the way, has been just very on top of things here in Whitman County. And I give him a lot of credit for keeping the health community and the rest of us community providers in the loop with weekly meetings. Anyway, we were able to work with Troy to get that employee tested at the Pullman Regional Hospital, has a triage testing center set up. Troy was able to make arrangements to go ahead and have tests done. And we did get the test results back in 2 days and were able to get an all clear so that we could begin putting our teams back onto the normal rotation of in-office and out-of-office service. So things are looking up right now. I did want to note that the Whitman County Public Health site does note that we have 13 cases rather than the 11 cases noted earlier. I'm not sure what the discrepancy is on the numbers there, but that's just kind of to get you up to date there. And so far, no deaths. And actually, I believe so far, no hospitalizations from any COVID infection cases. So with that, I don't really have a whole lot more to share. It is a little bit different perspective than some of the health providers and public health folks on the call. And if you have any questions, I'm happy to answer those.
Okay, thank you so much, Jeff. I'm struck by the notion of your work in food insecurity and as a challenge that COVID-19 has just accelerated, I think, in our communities. And I don't know if anybody else on the line has comments about what you're doing for food banks and food insecurity in your counties, but I certainly know from Spokane that's a big issue. Any other comments, questions of Whitman County's efforts?
Hi, Patrick, it's Joyce.
Hello.
Can you hear me okay?
Yeah. Yeah.
Sorry, I'm just going to come off my phone as well. Just in regards to the food insecurity, just as a reminder to the group that folks can phone 211 and get connected to the food stamp program immediately. We submit all their applications on their behalf to DSHS so they don't have to leave their home.
Okay, 211.
And right now, the governor has allowed the maximum award to everybody, regardless of income, for this month of April.
Great. Okay. Good. Thank you, Joyce. That's a very good tip. I was unaware of that. Any other comments to Jeff's presentation from Whitman? All right. Well, then I think we're keeping on track, but we want to definitely get Dr. Person. Pardon me? Somebody have a comment?
Okay. I'm sorry. I had some technical issues there, so I don't know if you guys heard me or not. I apologize.
You're fine.
Did you hear my information? Yeah.
Go ahead.
Sorry about that, guys, and I can put it in the chat box. It's just a reminder that folks can phone us at 211 to get connected to the food stamp program immediately without having to leave their homes, and that the governor did award the maximum
award to everybody for the month of April, regardless of income.
Great. And you can put that in the chat box, Joyce?
I will. I'll do that right now. And I also put some other resources in the chat box around employees being forced to work when they're not essential. There's a lot of resources out there with pro bono legal advice and unemployment assistance to help them with that situation.
Great. Thank you. I see them right now. Okay.
Sorry again for the technical issues. Thanks, guys.
Very good. All right. I see Ronnie's response. Okay, let's definitely pick up Dr. Amy Person before she needs to leave for her 11 o'clock appointment. And I don't know if that's going to be supplemented by Melissa as well from the Community Action Connection. But we'll start with Dr. Person. Can you tell us a bit more behind that very quick numerical sketch I gave earlier?
Sure. So yeah, our numbers, some of them look fairly dramatic, and a lot of that is driven in Benton County because such a high percentage of our cases have occurred due to outbreaks in long-term care facilities. And in fact, that is really where almost all of our deaths have occurred as well. So that, I think, skews our numbers in Benton County. Franklin County, our percentage, I think we are seeing that high because of the number of workers we have at Tyson that have tested positive. So yeah, typically when you see percentages, in that, over 10, where over 10% of the population is positive, it's either a sign of sustained community transmission or is, representing that you're doing more focused testing related to outbreaks, which I think is really what we are seeing, particularly with that higher rate in Franklin County. As we know, this disease does disproportionately affect our older population, and that's where our bi-county area is very different. So Benton County, 22% of the population is 60 or older versus Franklin County, where it is about 15%. So we would usually expect to see more burden of disease in Benton County. Again, testing has been somewhat of an ongoing issue, and I think it's really related more to just the nationwide lack of supplies that has meant that people who have a better line on testing, particularly with facilities, I think have done a better job acquiring some of those supplies. And that's where I think we've had a challenge in our area, because again, a lot of our providers were having patients go to the lab to get their testing done. So I think they were not ready to be able to do testing within their own facilities. So we continue to kind of work on that, and we've had support, even from some of our non-medical partners on that. I think the challenges we're going to continue to see moving forward with this is that we know a lot of people are asymptomatic or pre-symptomatic, and the challenge is trying to figure out, when's the best time to test someone who has no symptoms, and what do you do, when those test results come back negative. So I think that'll continue to be an issue until, the next needed phase that we will have in testing is the ability to determine who's immune, and that's going to be when we get antibody testing. There's a lot of it swirling around because the FDA has relaxed their, I won't say they've relaxed their requirements, but they, before they were pretty strict about not allowing stuff to be out there that hadn't been approved, and now they're sort of remaining silent on it. So there are a lot of vendors out there selling antibody testing So I think the challenge is going to be to ensure that when we do move to that phase, at least is something that has had somewhat some rigor applied to it in terms of it being used. So, you know, I think this crisis in Benton and Franklin counties has, you know, sort of shown us both highs and lows and kind of everything in between. It's allowed our healthcare system, had a number of them, to put into place the use of telehealth, which is, I think, something some of our institutions were already ready to do, but were just being held back because there wasn't adequate reimbursement for it. So this is something, again, where an emergency suddenly, you know, allows a capacity that exists to kind of be able to cut through the red tape and to be moved out there. And I think this is something that hopefully will continue once this pandemic has, or, you know, when we return kind of to our new normal, because I think particularly in areas where there are provider shortages, being able to use telehealth is going to be very helpful to get resources out there. I think one of the biggest areas where it's kind of exposed cracks, you know, particularly in our public health system, is really around the data. You know, the ongoing challenges the State Department of Health has had and the Public Health Lab have had, you know, just underscore there were repeated requests to the legislature for, you know, funding to improve that infrastructure, and the lack of that, you know, I think really was unfortunately kind of laid bare with this particular crisis, because that system could not handle the huge numbers of testing and data that has kind of it's been forced to synthesize. We have done a lot of work in our area, building on kind of our existing coalitions and cooperation. So we already had kind of our version of a healthcare collaborative, and we now meet daily with our hospitals and EMS to look at their challenges around readiness and supply chain things and their capacity. The other interesting thing that we have seen with this is that we now have weekly calls with our local decision makers that include both representatives from our city and county governments, our school districts, and some of our large businesses. And of course, these are people that I think in the past, you know, we struggled to get any audience with. So it has, I think this has given us an opportunity to kind of look at how we can all sort of work together, trying to figure out how to manage health issues in our communities. We had a lot of challenges, I think, with trying to ensure that our public was getting accurate information. There were a lot of rumors constantly flying around. So, you know, this discussion about the infodemic that's been associated with COVID-19, I think we saw definitely true here. You know, when we didn't really have testing and couldn't, you know, didn't have a lot to share around numbers of cases, you know, we were accused of suppressing that information and hiding things. So, you know, it was a challenge kind of trying to manage that. We stood up a call center just because of the volume of calls that we were getting in. And then thankfully we were able to make use of an MOU with 211 and to take advantage of their capacity to really shift a lot of those calls over. So that really helped us. We have, I think, 95% of our staff has in some fashion at some point done work specifically for COVID-19 to do our case investigation and contact tracing. We've been using not only our communicable disease staff, but our environmental health staff. Pretty much any of our staff with any kind of clinical or data experience is doing that. We've enlisted volunteers, but it's still been a challenge just to keep up with the sheer volume of cases that we continue to see on a daily basis. And then as we're sort of looking forward, it's, yeah, how are we going to manage kind of easing people back into a different normal rather than everybody sort of just rushing out to do things like they have been doing. You know, I like to think of it that I think life with COVID-19, because I think it is going to be several months before things return anything back to what they were before, and probably won't ever really be like what they were before. But I like to think about that this is really us trying to think as a county, as a country, about how to live with this new chronic disease of COVID-19 presence, because, you know, we will get to a new normal, but it's going to be a new normal that will be very different from our old normal. So if we can adjust to wearing masks, if we can adjust to maintaining some persistence of that physical distancing, we will be able to do all right. But if, like other chronic diseases, we just want to just go right back to how things were before, I think we are going to see a second wave of cases and deaths. So like I said, this has been really a very interesting and challenging series of times. We've been activated since February, and thanks to our collaboration with our emergency management, did shift our emergency operations center over to Franklin County Emergency Management, and both counties have been assisting us in those efforts. We've worked with our oh no, I'm blanking on the organization, but the one that does housing for us. They have done, DHS have worked with us in terms of identifying housing for those that are homeless, that are, you know, have tested positive or have been exposed, need to be discharged from the hospital. So that's another group we work closely with. So it's been interesting to me that, you know, before we had to distance ourselves, sometimes particularly in our area, because we have so many hospitals and so many agencies, there was a fair amount of fragmentation and not always a lot of ongoing communication between agencies. But now, you know, we're all sort of physically separated, but I think I have a lot more communication on a regular basis with many agencies and businesses and decision makers in our bi-county area than I ever had prior to this pandemic. I think the thing that we are also watching closely is, again, really going to be what is going to be the impact on our communities, particularly our communities of color and our communities that already struggled with some challenges around those social determinants of health. I think the economic impact of this is something that we are going to end up seeing fallout from this again for months to years following that. So that is my take on the situation, and if there's any questions, I'm happy to respond to them in the 6 minutes I have before I have to go.
Quick questions of Dr. Person before we shove on. That was quite a complete rendering of all the challenges, and to some degree some of the silver linings that you're facing, Dr. Person, as a result of COVID-19. So thank you. Any comments or questions of what's going on a bit in Franklin?
I have a question.
So, I have a question also. So John, why don't we go John first, and then Wes, and then that'll probably be our two questions, and we'll have to. John?
Amy, testing for COVID-19 infection seems to be limited to people who are showing symptoms in general. But currently, can EMS first responders who are asymptomatic obtain tests? And will screening of first responders be available soon?
Spoken from a head of a board overseeing a
fire district.
You know, I think that is one of those groups we're really trying to figure out, and I think that is something that as we look at the testing guidelines probably is a group that needs to be tested on a more regular basis, you know,
Yes.
particularly if they've had exposures, and then probably at some point even kind of serial testing. Again, I think somewhat of the challenge has been the supply chain stuff, but I absolutely agree. I think first responders and our healthcare workers, in addition to our long-term care facilities, I think all those groups probably represent ones that we need to think beyond just testing symptomatic, but probably, you know, doing asymptomatic ones that have been exposed. So that, I think, is one of our priorities, to figure out exactly how we make that happen when supply for specimen
Yes.
collection vary quite a bit across our area, but that is a priority, I think.
Thank you.
Thank you, Dr. Person. And Wes, real quickly, because we're running a bit late now.
Dr. Person, thank you so much for that very insightful, thoughtful presentation. It's very interesting to hear all those issues at hand. My question relates to your observation, actually your observations around data and your observations around communities or populations of color. And I'm wondering if you're seeing that going forward, there might be more opportunities to get more granular detail, perhaps at the county level, about demographic breakouts by race and ethnicity.
Yes, you know, I think there will. I think, you know, again, the challenge we've had now in terms of trying to interpret is that, you know, early on testing was really focused more on hospitalized and then long-term care. So I think it kind of skews what that data looks like, because at least in our area, you know, demographics, age versus race and ethnicity, there are some significant differences in terms of, for example, our Hispanic population is largely younger compared to our white population. So I think we have not seen testing as available in those. I'm hoping that as more of these rapid testing platforms, particularly the point of care testing, becomes available, we will be able to do somewhat more wide-scale testing. Although, again, I think there will still be the challenges if we know based on these other studies from Asia and other places that at least 25% of people are asymptomatic. You know, what does a negative test mean? Does it mean somebody isn't infected? Does it mean they're infected, but the test hasn't converted yet? Does it mean it was somebody who was infected and is now immune? So I think we are also going to, at this stage, really need to look towards that next phase when we get some decent antibody testing, so we can actually start to interpret, you know, what does it mean, this giant chunk of people we've had that we haven't been able to test? Have some of them been infected and are now immune, or are they really people that have not yet been infected? Because I think that's going to also help us look at, you know, safely returning kind of to a more physically connected society. Because, you know, with most infections, you probably need at least 70% of your population to be immune to not have sustained transmission. And right now, the only way that's going to occur is people getting infected. We don't yet have a vaccine, and that's likely going to be 12 to 18 months before we see that. So how do we determine, what percentage of our population is immune? We don't know that right now.
Hey, Dr. Pearson, this is Sherry Snow White. I have a question more on a health aspect. Will there be, or has there been, an opportunity to test the people that are coming up positive and also people that are coming up positive that are not faring well, testing their metabolics to see what's going on with their body, their insulin levels, to see if those are the people that are more vulnerable as well?
I don't know about that specific testing. We obviously know that people with underlying conditions, including, diabetes, are at higher risk. But, I think the challenge with this being a novel infection is, I think it's going to end up being, as we look back on what has happened through, through the course of time, we're going to have a better understanding of it. I mean, honestly, the thing that scares me in this country in general is that 45% of adults have an underlying chronic health condition that would put them at higher risk for severe disease. And if that is not an argument for doing a lot more around prevention of chronic disease moving forward, I think we can add, to that when we're messaging the public that besides the other health benefits, saving you from the next pandemic, is the best reason to stay healthy.
Amen. I'm with you on that one.
All right. Well, thank you. Thank you, Dr. Person. We kept you 2 minutes over, so appreciate your spending time with us this morning. Melissa, did you have anything to add from the Community Action Connections perspective of Benton Franklin? Is Melissa on the line?
Oh, good morning. Sorry, can you hear me?
Right.
Okay, so I was just going to speak a little bit about Community Action Connections and what we're doing and how we've modified our services a little bit to address more of those social determinants of health. And so really what we've seen is an increase of people calling just for information, for resources. And so really connecting them to the services they need, assuring them, that there are services and resources out there that can help them with the different needs that they're experiencing. We received an increase in our LIHEAP dollars, which is our low-income home energy assistance program dollars. And so we're still trying to enroll participants in the programs so that we're able to meet the needs that, although utilities may not be disconnected at this time, that doesn't mean that those that have been financially impacted by the COVID-19 are not still going to face that huge bill when those protections do go away. We've also looked at, we're working to reach out more to our current customers that are in our permanent supportive housing projects, just checking in with them. They're generally a more vulnerable population. So making sure that, they're okay. Do they have the things that they need? We're lucky enough that we have a partnership with Second Harvest. So we're able to put together food boxes or some hygiene supplies and either coordinate for pickup services or dropping them off at their homes. And I'm trying to think what else. A lot of it too is just working towards preparing ourselves for the impact, when this kind of slows down a little bit, what is the outcomes and sort of the consequences of the outbreak. And so preparing to provide the best services that we can. So that's all I have.
Okay, so maybe what you typically do, except now on steroids or an accelerated pace. Would that be a fair characterization?
Very fair. And then it changes daily with new information that comes down, that we're always trying to take what we learn, tweak it, and do it better.
Yeah, I think we all can relate to that. Okay, let's continue moving west, and Catherine from the Yakima Nation, are you on the line still? Catherine Saluskin, are you still on the line? Okay, well, let's see if she will appear. But in the meantime, Steve Mitchell from the Opportunities Industrialization Center, are you available, or the clinic?
Patrick Steve wasn't able to attend today.
Oh, okay.
However, I think Lisa's on the line, isn't she?
Yes, this is Lisa Campbell-John from Yakima Farmworkers Clinic, Northwest Community Action Center. And I actually have Janice Gonzalez, who is our senior manager of our emergency services, that will give a report for what we've been, and we're reporting from the Community Action Center, not the clinic perspective.
Okay, well, please proceed then. I'm sorry we don't have you listed.
Hi, this is Janice Gonzalez, also with Yakima Valley Farmworkers Clinic Northwest Community Action Center. So we've been initially concentrating on developing new ways of delivering the services so that we could continue to provide service.
Janice, are you there?
Oh yes, it just now I've been talking for about 5 minutes.
There's a buzz in the connection that I'm sensing. Are others getting that too?
Okay, let me change how I'm just a minute. Is that better?
No. No,
Okay.
go ahead. Let's see.
Okay.
I think it's better now.
Okay. Okay, so initially we spent some time developing ways on how we could continue to provide services in our community. We're primarily focusing on emergency shelter in the form of hotel motel vouchers. We're looking into expanding where we provide those trying to find other options for hotel motel vouchers. The other big request that we are receiving now, and I think Melissa from Benton Franklin community mentioned it as well, is that
it was telling me something. Anyway, sorry for the. We're also concentrating on energy assistance, low income energy assistance, because most of us have received additional funding to provide services in relation to COVID. And basically every low income household has been impacted. We provide services to low income households. I should mention also, in many of our programs, the income criteria has increased, so we can provide services to more people who have been impacted by COVID. And I'm going to just leave it there and let anybody who wants to ask questions.
Okay, thank you. And also, anybody else from Yakima would like to weigh in about what's happening in your county? The county that has obviously been hard hit by COVID-19.
Yeah, this is Lillian with the Yakima Health District. I'm happy to give a quick overview.
All right, real quickly, and then we'll have questions for both of you.
Yes. So first and foremost, I want to echo what Dr. Pearson said, that even though everyone's life has been completely ended, there's definitely hope and opportunity in all the different innovations that our partners have taken on, and in all the partnerships that we've been able to utilize to respond. So yes, in Yakima, as of yesterday, there are 674 cases here in Yakima County. Today or early tomorrow, will likely surpass 700. Unfortunately, we lost 29 individuals in our community, and 22 are currently hospitalized. Something I keep in mind is that we too have outbreaks in our long-term care facilities. There are currently 5 out of our 11 long-term care facilities that have current COVID-19 outbreaks. So about 180 or so of these positive COVID-19 cases can be attributed directly to those outbreaks. Unfortunately, we haven't had a surge in hospitalizations as we had initially predicted, which is great, but it also poses challenges moving forward as it's been expressed repeatedly, that we even though we've been able to flatten the curve, so to speak, that's not an indication that we need to lessen up any of our public health recommendations. So that is going to be a challenge moving forward to ensure that the community remains on board and committed to staying at home as much as possible. In terms of other hotspots that we're going to start looking more deeply into is, of course, in Yakima, we have a huge workforce that's based in agriculture and others that are considered critical infrastructure workers. So I think that's about 60% of our businesses remained open even with the stay-at-home order. So that also produces unique challenges, and we'll likely see more investigations and testing having to be in place in places of employment as the primary exposure site moving forward. So that's going to be our focus moving forward, and just a quick overview of what's going on here in Yakima County.
Okay. Questions of the two speakers? I'm sorry, I didn't catch your name.
Lillian Bravo with the Yakima Health District.
Lilia? Okay.
Yes,
Thank you.
Lillian Bravo. Thank you.
Okay, Lillian, yeah. So any thoughts from the other counties about what can be learned from Yakima? I'll just say, Lillian, I'm an economist, and I'm developing a tally of job losses in Yakima County sometime this afternoon, and I think you're right. I think that among the counties I've done this for, I will find that Yakima County has actually shed the fewest jobs in the short term, just because of your huge agricultural base, and with that obviously comes the social distancing issues that all public health people are working toward.
Yes. So that places unique challenges in that we want to obviously protect the community, but when a business is considered essential, that we also have to work to make sure that we can maintain critical functions moving forward. So it's definitely a delicate balance to play.
Right. Okay. Yes.
Patrick, this is Carol. This is Carol, and I guess I have a kind of a question for Lillian and Janice. And maybe it's the elephant in the room, but of the cases that are in Benton and Franklin counties, and there's a high proportion of Hispanic that are affected, Hispanic people, there's a relationship between the workforce and Latinos and the number of cases. We know that in long-term care, it's not the most profitable place to be employed. And look at Tyson, the Tyson workforce. I have actually been out there. I agree with Megan. It's not a very pleasant place to work. A lot of, Hispanic population in those professions too. So I'm seeing a correlation between long-term care facilities, low-income populations, and cases of COVID. And maybe I'm drawing the lines too dramatically here, but I'm wondering if our EPIs in Yakima and Benton and Franklin counties are also looking at the same kind of data and drawing similar conclusions.
So I can speak for Yakima. In Yakima, we of course have had significant health disparities before COVID-19, and we're starting to see the same disparities play out with COVID-19. So we were able to map out the place where everyone lives geographically across Yakima County, and when you look at the geographic disparity, it's also in the lower valley, much like with many of our negative health outcomes in the past. So we don't have enough data on race and ethnicity, unfortunately, here locally. I think more than 50% of it's actually missing. So that's a challenge to be able to make some of those correlations right now. But I feel like that's, once we have that data, and from just what we're seeing right now, that's likely accurate.
Okay, thank you, Lillian. Any other questions? Any other voices want to weigh in from Yakima? All right. Well, we're back on schedule, and we'll wrap up then in our northwest part of the district, and that'll be from Kittitas County. And Sue, are you still on the line?
Susan Grindle is still on the line.
Oh, wonderful. Okay. Well, you're on.
Great, thank you. Susan Grindle, CEO of Hope Source, which is also a community action center in Kittitas County. When I look at the experience in Kittitas County, it seems like there were 3 reasonably specific habits that the county had that allowed it to have almost immediate coordination and very clear messaging and very clear understanding of roles, who was going to play what. And those 3 things from my perspective were the EOC, the Emergency Operations Center, periodically runs disaster preparedness. So they knew each other, the community providers knew who they were, knew how they operated. So it was very easy to understand their role. And then being a LIN from the GCACH, being Kittitas County Health Network as a LIN, had been in place for a little over 3 years and had a structure. So it had a board of directors, it had a leadership council, and the membership of that LIN is extremely broad-based in the community. And so people who were needing to come together had been working together, knew who each other were, knew what people did, knew the limits and the roles. And so they were able to deploy quickly into whatever the directions were that were coming down from the public health officer. And the third thing that I think worked in our as far as I can tell, worked to our advantage is the fact that the city and the county quickly worked together. They didn't, they immediately within the first week began setting up meetings and coordinating communication, setting up different task forces that would carry out both the communication, for example, the messaging, the recovery, working closely under the public health officer and working closely with KDH. And thank you, Dr. Martin, for all of the work that your crews did so quickly. I really appreciated that. So with that in place, that came together within the first few days of the announcement, and the messaging went out to the community in a very consistent and clear way that allowed people to count on what they were hearing and to adhere to the types of things that the public health officer or the healthcare system was sending them, because there was one website they could go to for all of their information. The county hired a consultant. They set up a website very soon so that you didn't have 32 different people coming at you. You had one place you could go that had links to everything you needed. That really helped the feeling of security and safety and the ability to move forward. So when the stay in place message came down, people understood that they needed to do that, and they did do that. And you know, I think that helped immensely as well. So for those reasons, it was really, it really has been nice to watch this county come together with all of the different pieces of resource that were needed without battling back and forth amongst any of them. They just simply knew each other. They knew what they needed to do. They trusted the people they were working with. And so it really, I think, accounts for why we've seen the numbers that we have and the safety that we have seen in this county. As a community action agency, we did receive funding from Commerce to house homeless, couch surfers, and people displaced out of the community that needed to be isolated or quarantined. That was a big help, but again, we were part of the infrastructure. We understood all the partners, and it was easy to communicate and work under the direction of the public health officer in making decisions about the COVID part of the operations. So it went, I think, about as well. Now, that's only my perspective, but it went about as well as I think you could do it as a whole county and a community.
Okay. Thank you, Susan. And anybody else from Kittitas, would you like to add a comment? Dr. Kevin, are you still on the line? Apparently not. Okay, then questions of what Kittitas has done. Let me just turn it over to all of you then. Do you see in your respective counties the kind of coordination between the public entities, in particular between county and cities, like Susan just reported out for Kittitas, or has that been any sort of a rub or irritation in getting things moving in the right direction? Not an issue, huh?
This is Rhonda, Patrick. I think I made my comments very early on, but I think that's been one of the very helpful pieces, at least in Yakima. And if Lillian's still on the phone, thanks to Lillian. But the health district has been very communicative in terms of our protocols, and it's one of the things that's kept us all going in the same direction in terms of how we test, who we test, and then our communication with the other health providers. So I think that those relationships have been very important and very helpful.
Thank you, Rhonda. And we seem to have that same message from Dr. Person, talking about if there is a silver lining from her perspective to this terrible pandemic, that she sees participation and movement forward in public health areas that she hasn't seen since she's been in the job. So I don't know whether that's true in other counties, but it's nice to hear that it seems to be happening in several counties.
So Patrick, this is Carol. I made a comment in the chat. I made a comment in the chat box. I think it'd be really helpful for the ACHs to be included in some of these discussions. We have not been included with the Benton Franklin Health Department in terms of getting on the ground information about what's happening with their EOCs. So I sent a message to Dr. Person that I hope that she picks up on, but I feel like we've been somewhat left out of the mix when it comes to understanding the issues and the challenges in our region. And I know it's a really very fast-paced, daily changing environment, but we are in the healthcare provider helping business. We've provided funding for telehealth across our 9-county region. We are donating $300,000 to the food bank. So we feel like we're an important player in trying to help and assist our partners. And I hope that they can take advantage of some of the things that we're doing. And I wanted to thank Martha Landman for her shout out to GCACH. We really appreciate everything that everybody's doing on behalf of our community.
Hey, Carol, I can send you that information later by email if you don't hear from Dr. Amy or the health department.
And I think it's mostly just this on the ground information of what's happening with our providers so that we can assist in this place. Thanks, Joyce. I appreciate that.
Yeah, I'll send you the link to the meetings. Thanks.
Okay. Well, we've heard a lot today, and I'll just repeat what I said at the start of the session here, is that this was not in the planned yearly calendar for Leadership Council agendas, but we hope that it's been worth your time. I see that most of you are still on the line. Thank you for staying the course, and perhaps we just need to do this at subsequent meetings on a more limited basis, just to check in to see what's happening. I heard quite a few success stories, and I heard some challenges, which was what I think we had asked you to consider. And thank you for putting your thoughts to that. I heard challenges coming from the notion of things change quickly. Sometimes directions from the state and the feds are not too consistent. We've heard some challenges, as we all know, about supplies, whether they're PPEs or whether they're tests. And I think we all know that we have hotspots in most of our long-term care facilities, and how those are being handled is a challenge, I think, for every single county. I just want to see if we have any ending comments that folks feel qualified to answer on where we think we might be in a month with this kind of a conversation? In particular, will we have bent the curve in your counties? Will we be actually doing surveillance and antibody testing? Do people have a sense of that? And therefore, will we have just a little more calm to what has been probably the largest disruption to our lives perhaps ever? So anybody have some closing thoughts about where they think we might be in a month?
No.
No future casters?
Let's just hope for positive outcomes.
Well, then we'll just muddle through doing the best we can. But if we're to look at the epidemiological evidence coming from the state, I think that we can say that we are bending the curve, and the question is how fast and how well and what that will mean. But I'm sure COVID-19 will preoccupy all of us for the foreseeable future. Any last comments from Carol or staff?
Thanks, Patrick, for facilitating. I know it's a lot harder when it's all virtual, but you did a great job today, and we had great presentations from everybody. And thanks to Wes for setting those presenters up.
Yes, yeah, and I just want to say thank you to all for your commitment to this. This is in the midst of this kind of trial, or not kind of trial, in the midst of this severe trial. It can be very inspiring to see what people are doing, and that's the way I'm going to leave this meeting in my mind anyway. So with that, our next meeting is it May 21st, Chelsea? I think it is, right? The next meeting?
Yes.
May 21. So a little more than a month from now. And let's all hope for great weather and keep those efforts to bend the curve. We are adjourned.
Thank you.
Thank you.
Thanks, everyone. Have a great day.